Statistics. I'm joined here today with Dr. Randy Phelps, our psychologist in our autism team. We're going to be discussing all things autism today, and we're very excited to be with you in this first Neuroscience Grand Rounds of November. So just a couple of disclosures on my end. Nothing is currently relevant for me, and I may be discussing off-label use of medication, but very generally. So for my presentation today, and Dr. Phelps's has her own objectives, we'll be discussing the prevalence of autism spectrum disorder and updated diagnostic criteria, describe modalities old and new used to diagnose autism, and recognizing the most common co-occurring conditions in children with autism and their treatment options. Just different, not less is a perfect way to describe our kids with autism. It is really about a different way of understanding them and how to support them rather than anything much less than that. So as you all may be very aware, the prevalence of autism has certainly changed over the years, especially over the last 24 years or more. Where we're at currently is 1 in 36 children are known to have autism diagnosis. So a question I get asked a lot, we all get asked a lot, is why? Why is this occurring? Why are we seeing this increasing prevalence? And there is a lot of variety of thoughts on why this is existing. In 2020, a publication put out some ideas and some perspectives on this. So for the first is that there is continuing ongoing revisions of the Diagnostic and Statistical Manual of Mental Disorders. So we'll be going over those updated diagnostic criteria and how that's really looked through the years and why that may afford this understanding of the increase in the prevalence of autism. There is also increased public awareness of the diagnosis and symptoms, and there is now universal screening, which we'll also go over, which all really kind of ties into each other. And then there's thought that maybe there's a possible true increase in prevalence that we don't really at this time understand why that's existing, right? Are there any epigenetic factors? What's going on? So diving a little bit into the history of autism, which I think allows us to understand, why we're better at diagnosing, where we've come from the beginning, which then leads to wiser increased prevalence. So Leo Kanner first described infantile autism in 1943. He coined it autism or severe problems in social interaction and connectedness from the beginning of life. There is and additionally some resistance to change or resistance on sameness. But some flaws with his perspective is that there was blame on the parents of these children as the cause of their presentation. So we've gone definitely much further away from that understanding in that there is no blame on the parents for the diagnosis of autism. Hans Asperger in 1944 described a broader phenotype with social difficulties, circumscribed interests, but generally more better verbal skills, which is what will lead into the diagnosis of Asperger syndrome, which we don't utilize anymore. Certainly lots that went into why we don't recognize that, which I'll go into a little bit. So here is a little bit of the path of which the DSM has changed over time. So the DSM-2 described a form of childhood schizophrenia, and then DSM-3, we became a little bit more refined in our understanding of this as a distinct autism diagnosis, and then they also listed pervasive developmental disorder not otherwise specified. And there was a few reasons for that, right? So the autism versus the schizophrenia, so age of onset. So autism is early childhood, family history. So family history of schizophrenia would lean more towards a diagnosis of schizophrenia rather than this autism. So there's a lot that was allowing us to understand that the schizophrenia, this infantile childhood schizophrenia, is a lot different than this autism diagnosis. And then in DSM-4, we then saw these 3 categories of autism, Asperger's, and PDD-NOS, the pervasive developmental disorder not otherwise specified. And then in the DSM-5, it was all combined into autism spectrum disorder. So again, we don't use PDD-NOS, we don't recognize Asperger syndrome anymore. And And the term spectrum really indicates that it's, right, a line of some sort, right? That somebody can fall on one end and another person can fall on the other end, and we all are somewhere within this spectrum of existence in autism. When the truth of the matter is, it's really more of this array of sorts, right? Where someone may have challenges in one area within the autism criteria, and someone may have challenges on the other end. But on the other sides, they may be thriving in some ways. So the spectrum is a little bit of a misnomer, I would say. I mean, I think we've come a long way in the understanding of autism, where spectrum, in many ways, allows us to describe this as a broad phenotype, but I think it then does lend to people expecting someone to land in a specific spot on it, which we'll go over in a little bit, where we know that that's not the case. And so what changed? Why did we take away Asperger's syndrome? Why do we take PDD-NOS to have this autism spectrum disorder? Well, we understand that there's significant variability in the number and severity of autism symptoms between and among subcategories with similar core symptoms, right? So someone can have someone can be lining up things, repetitively, but be very, not have a very highly focused interest. And I'll go through all the criteria in just a moment, but it's just so varied and broad. There's no predictive outcome based on whatever subgroup you are, right? You can't really say what anyone's going to do, whether they have Asperger's syndrome or autism spectrum disorder. We really have poor diagnostic clarity between subgroups, so it wasn't a really clear distinction of who would qualify or fall into what criteria. And there may have been possible restrictions on eligibility for treatment depending on what subgroup they fell into or were determined to fall into. So to go over the core criteria a little bit, so there's two at this point that we understand. Persistent deficits in social communication and social interactions across multiple contexts, as manifested, and this is the DSM-5. There's a little update, which I'll go over in a second. Social emotional reciprocity, nonverbal communication, and relationships. So I would like to highlight here, because I think this is a common misunderstanding of autism, is that lack of verbal communication skills is part of their criteria, and that's not the case at all. Certainly, many children with autism do not have good verbal communication skills, but it's truly the deficit in the nonverbal communication skills, regardless of whatever their verbal communications are, is where we understand autism to be. And then we have the other category, which is restricted repetitive patterns of behavior, as manifested by two of the following: stereotyped or repetitive behaviors, insistence on sameness, focus, interests, and sensory differences. So updates to the DSM-5, we have these text revisions that come out. There wasn't much, but specifically in that first category, there's just some language that was edited, which really is how we understood it anyways. I think the new update just reflected it. Whereas in this first section, the persistent deficits in social communication, a person would need deficits within all three criteria to meet criteria for autism diagnosis. So I'm going to talk a little bit about severity levels, because this is another question that I probably get asked most, is what level is my child? What level is this child? The DSM-5 does delineate 3 levels of support a child could need. 3 is requiring very substantial support, 2 is requiring substantial support, and level 1 is requiring support. And it does describe pretty, relatively subjectively, I would say, where a person could fall within these criteria. And so in theory, we could, but I think there's another point about these levels. They're not intended to be a quantifiable score to monitor progress or determination of where on the spectrum a child is, right? This is probably the most common misconception. They are dynamic. They are moderated by environmental factors, interventions received, how old the child is. I mean, there's so many factors that could play into how much support our child needs, regardless of, progress at some point that they were making. They don't factor co-occurring conditions. They may be more of a reflection of cognitive limitations. But I will tell you, in my practice, even though I don't think this is a widely, I'm hearing more of it within the developmental peds world, is I've really gone away from labeling this within my notes as a child, because I think that many ways it puts a child into a box rather than opens the door up to the options of support for them. So I really have a conversation with families about, why does this exist? What does it mean? And why I think, why we have just autism spectrum disorder. And then some qualifying diagnosis, right? If they have intellectual disability, if they have a speech and language impairment, those are much more valuable for them than to label a level on a child, because we do expect that to change. We hope for that to change in many ways, right? We expect it to, things just to fluctuate all over over time. And this is really why, right? This is a really great picture that describes our understanding of autism, right? There's so much that plays into what we understand about people with autism, those core criteria in the purple and orange circles. And then the yellow circle, it's their intellectual abilities, their blue is their language skills, their green is their adaptive functioning, right? Many of those play into each other, but some are very separate from one another. And then around this kind of more central area are other factors, other diagnoses that we know exist with children with autism spectrum disorders and can very much impact them at different ages, different stages of their lives. So we do recognize that we need some way to understand the needs of individuals. There's potential focus on patient-centered outcome measures. The Lancet Commission recognizes this profound autism label, if you will, but more of a recognition of a person, because we do know that children or individuals that really need that around-the-clock support really benefit from having that be understood by others, by support services, and so on and so forth. So the idea is that we recognize this profound autism, those that are unable to care for themselves and need 24-hour supervision. And we also need to support research for this group, which are often left out of the research space so we can really best understand how to help them. So early diagnosis, this animation didn't go, but so the bottom left map, of course, as you all recognize, is Arizona. This is really where we're currently at with average age of diagnosis at 47 months. In the United States, the average age is 49 months. So currently we're not doing as well as the whole country, but really Arizona and the whole country, we can be doing much better on a whole, because autism, we know, can be diagnosed less than 2 years of age. Sometimes the symptoms don't become apparent until later in life and social demands increase, but we really need to be striving to recognize and diagnose autism as early as possible. So the American Academy of Pediatrics recommends screening at 18 and 24 months of age. Early intervention across the board gives the best start possible. It can improve long-term outcomes, maximizing developmental gains, reducing symptom severity, and shown to improve effective communication and social emotional reciprocity. And really, for all of our kids, we want them to reach the highest potential, and getting them into early intervention services and early supports really is the best chance for that. In early intervention, goals can include communication skills, cognitive skills, social skills. We could get speech therapy involved, occupational therapy, ABA therapy, among many other therapies that these children often benefit from. So how to make a diagnosis? Well, we have the Autism Diagnostic Observation Schedule, which really continues to remain the gold standard. It is evidence-based, it is display-based. The caveat is it's expensive and it can take some time to administer. So it's not something that is a quick and easy diagnostic tool necessarily in the clinic space, but it is very good. The question is it always needed? There has been thoughts and times in which an ADOS was, given to every child for the diagnosis of autism. There was an article published in 2022 in JAMA. It was it was a group of clinics across the country that really collected data on this question. It was almost 350 children, ages 18 months to 5 years, 11 months in 8 sites, 7 in the US and 1 in Europe. So essentially looking at developmental behavioral pediatricians and the ADOS, right? Specifically for people who have the fellowship training, is an ADOS always needed to diagnose autism? And they found that that's not the case, that for a developmental pediatrician who felt strongly, confidently in the diagnosis, that generally correlated diagnosis, or no diagnosis, I should say, with the same ADOS score. So it's this is a really important study, right? Because as you all probably are all very aware, wait lists in developmental pediatrics for psychology for autism diagnosis are really long. And so eliminating the need for every child to have this lengthy evaluation and to just be seen by a developmental pediatrician affords them to receive a diagnosis sooner, to start to work on shortening our wait list as much as possible. And this picture below is the box of toys that I have in my Scottsdale clinic. And I can tell you, I can get a lot of information from having a child play with this. So if you can see, there's like a stack of maybe 5 magnet tiles. There's a little fire person here, some shaped blocks. Used to be work belt, I think. It's something that you could say looks like a phone, and maybe a wrench of some sort, and a hammer. And I tell you, a child can show me a lot with this, either a really, great imagination, some great, play skills, or a lot of repetitive behavior, some stimming behavior. So again, for myself, sometimes I do need an ADOS, I will say that, but sometimes we just need to get some good clinical observations. And there's some new stuff on the horizon as far as diagnostics. Eye tracking is kind of in fashion and getting a lot of attention right now. Atypical eye gaze is often found in individuals with autism, and there is thought that this can be an early indication of a diagnosis of autism. So there has been some studies that looked at this idea that distinctive eye gaze patterns were detected in toddlers with autism. A further study looked at younger children and found that it was predictive of an autism diagnosis. So it's a movement in an interesting and possible new direction for diagnosis, but we do need more long-term studies. We need to understand the feasibility, reliability, and efficiency of utilizing this method. And then telehealth. So COVID-19 pandemic, the shutdown, telehealth skyrocketed. We utilize telehealth every day in developmental pediatrics to evaluate, diagnose, screen children for autism. And it can be done, and studies are supporting it. So it tends to be younger children, those with higher autism symptoms, those with an educational diagnosis already. So some good work by Dr. Phelps herself. I'm just going to play around that one. Pros are children are comfortable, right? They're in their home environment. They have their toys around with them. It's far-reaching, so our families that live in more rural areas are able to better access autism diagnostic services through this. If utilized properly, right, if we can get the family to turn the screen around or have the screen face the child so we can just watch them play, direct families to maybe utilize certain toys or do certain activities, it can really afford us a lot of really good observations. Sometimes the children really struggle to participate even when they're home, just when they know that something's going on. And it may still warrant that we get them in to be seen. There is a tool put out by Vanderbilt, which is looking at, a structured telehealth assessment tool. So I'm briefly going to go through this, autism and co-occurring conditions. So again, going to revisit this picture because I think it's a right reminder to all of us how complex autism is, that there's so much that factors into it, just like all of our children, but our kids with autism even a little bit more so than others. One is motor coordination difficulties. And I will tell you that when this first, came out, when we were first understanding this, I was pretty surprised that this became kind of top of the list for co-occurring conditions. So the Spark study in 2020, which was a large autism database in the US, found that there was a high risk in children with autism for motor impairment. Very few are receiving or receive physical therapy, and that motor skills can closely tie into social communication skills. So, for instance, walking will lead a child to sharing objects with their caregiver. Head motions, moving a head back and forth, will then allow us to look towards other people. Arm movements then allows us to utilize nonverbal communication skills like pointing and gesturing. And early intervention and motor coordination can facilitate growth in these skills. As kids get older, we know that evidence supports early access to physical therapy services, and autistic children continue to benefit from recreational therapies like yoga, dance, adaptive recreational sports, and outdoor play. I will tell you, a lot of my older kids, I encourage families to get them involved in sports, whether adaptive, depending on their needs, or more of a traditional route. I think it allows children to, work on those motor skills, but also to engage with others in a social way that can be pretty naturalistic, if they're enjoying that sport. ADHD. So ADHD and autism is an understanding that's evolved. So DSM-4 to DSM-5, we recognize that autism and ADHD can occur together. So that was a big shift. It can sometimes be hard to distinguish, and our standardized tools are not validated in autism, but they can be used to determine impact of symptoms and monitor progress over time. And for children with autism, ADHD can cause functional impairment. So it is important to recognize and treat it accordingly. We also want to rule out other factors such as any kind of speech and language impairment causing inattention, distractibility, even impulsivity at times. Perceptive interest can cause internal distraction. And I will say it's not always a very easy distinction to make often, because we may not know if that's existing. But overall, we're doing our evaluations. We're getting assessments in both environments like we do with any other child with ADHD. Because it is important to recognize, because they do exist in treatment of ADHD, just like any other child with ADHD, can eliminate the stressors that are caused by an under-recognized diagnosis. For treatment, there's evidence-based behavioral interventions and medication. We can see lower efficacy and higher adverse effects in children with autism, but we just monitor them like everybody else. The mantra, I would say, that exists not officially, unofficially, amongst developmental pediatricians is start low and go slow, because a low dose may be really effective, and that's great. So recommendations are still to start with a stimulant, and if not successful, then going to alpha-2 adrenergic agonists or other non-stimulants like atomoxetine. There was complex ADHD guidelines that were recently published a couple years ago that really, like here, kind of map out what a clinician can do when diagnosing or treating ADHD and coexisting autism. There's just another map of that recommendation. Anxiety disorders can be seen in children with autism. Diagnosis, again, can be a little bit more difficult. We may see overlapping symptoms. Children may have cognitive and or language impairment, so they're not actually able to describe typical descriptors of anxiety that other individuals may be able to do. And individuals with autism may have a difficult time reporting emotions. But it can manifest as behavioral challenges, increased perceptive or stereotyped repetitive behaviors, or even GI or sleep disturbances. And so it's really important to at least be mindful of it and start to kind of think about this in a child where, traditional supports and services may not be effective, or we may not be getting the outcomes that we're thinking. So treatment for anxiety in children with autism. I'm going to talk about this briefly because Dr. Phelps is going to be going into just behavioral interventions overall a little bit more. But behavioral interventions are highly valuable. Various factors to consider when recommending, the child themselves, their cognitive abilities, their language abilities, and so on and so forth. Medications can be extremely valuable as well. SSRIs are first line for treatment of anxiety in children with autism. Studies with dosing are in typically developing youth with anxiety, so we're not have clear guidelines in autism, but again, start low, go slow. We may see hyperactivation in children and youth, not you, with autism, and always discuss the black box warning, as we should be doing in any person that's started on an SSRI. Alpha adrenergic receptor agonists, we may see some benefits, but not as great as SSRIs. And when I'm going to when we do this, it may be the ones that are a little bit more manifesting in that hyperactive, impulsive, where there may be some anxiety wrapped into that as well. So this is from an article kind of discussing those options for anxiety. So that's for me. I'm going to stop sharing so Dr. Phelps can take over, and then we'll answer questions at the end.
All right, I am gonna do my best to share my screen. This rarely goes well, so we'll see. All right. Okay. Now. All right, can you all see that? Okay. Okay. So I am excited to continue our conversation and discuss some interventions that are often recommended for children with autism, as well as children who have autism, as well as a co-occurring condition. So we'll talk a little bit more in detail about anxiety and depression and some of the psychological interventions that might be useful for those kids. But first thing is first, I don't have any financial disclosures. We're going to be discussing pretty briefly some of the historical and current whys of intervention, why we're doing certain things, how those interventions came to be, and what the contextual factors are that we need to really consider carefully when thinking about interventions. We'll talk about what some really common interventions are for autistic youth who have just autism or have also co-occurring conditions. And then I hope that we can kind of discuss some skills and strategies for providing more individualized recommendations. First thing is first, though, within our context, or really operating from a medical perspective of disease and disability, meaning that we are trying to identify a specific problem and then offer solutions or recommendations for that person. That's really important, and I think that it is really formulated within our entire history. What we know more recently, though, is that there is a social model of disability that really emphasizes the environmental structures and recommendations that we can make within our environment and society to accommodate someone. Oftentimes, these two models are discussed as disparate from one another. We're thinking about the problem lying within a person through the medical model and the problem relying within our society through the social model. I think both of these models can actually be complementary to one another, where we can offer interventions for that person, but then also recognize that there are pretty clear and critical accommodations that need to be made within our societal structures. Now, there's not a single way that we have agreed upon talking about autism. So many of us have been trained to use person-first language, meaning that a person has a diagnosis or a person with autism. As we're learning more from our self-advocates who've been diagnosed with autism, we're hearing that a lot of those individuals who can express that opinion are preferring identity-first language, meaning that that identity is part of many identities that that person holds and can't be completely taken out of who they are. And so identity first language is a preference of a lot of autistic self-advocates. That said, because when we think about large populations of people, everyone has a different perspective. Today, I'm going to be using both identity and person first language to respect both perspectives. And some of those preferences depend on kind of functional impairment, cultural differences, how one identifies and develops that identity. So there's a lot that goes into this, but today, for the sake of this, I'm going to be using both, but I encourage you to ask your patients or whoever you're working with how they prefer to be identified. In order to understand the interventions that we are offering, I think it's pretty critical that we dive back a little bit into the history of how people with disabilities have been treated. Um, the maltreatment of people with disabilities is truly embedded within our history. Autistic people have been dehumanized and undervalued for centuries. Of course, we didn't recognize them as having autism for many, many centuries, but ever since identified, we know that there have been blameful and scientifically inaccurate theories that have been put forth that Dr. Raz described too. I'm thinking about Bruno Bettelheim's refrigerator mother theory and thinking about how that was a theory identified as a cause of autism. So mothers who were unaffectionate or cold were the cause of their children's autism. We of course know that this is not true. However, this theme that was born out of these blameful and inaccurate theories still holds true today. We still often have parents ask, well, am I the cause? What did I do when they were an infant? Did my behavior impact this? And I think that's important to know as we think about how we're putting forth interventions and how we're talking about autism. Many goals throughout history of interventions were geared towards making autistic individuals indistinguishable from neurotypical people, meaning that we were trying to make people look as normal as possible, right? Whatever that means. But in efforts to do so, we were utilizing punitive and abusive measures to really try to make people fit within a mold. We were also using powerful medications, experimental procedures, exclusion and seclusion methods. And unfortunately, I would love to say that this was completely out of existence today, but we'd be naive to think that that stigma and discrimination and some abusive strategies didn't continue to exist today. That said, we have made pretty significant strides in embracing neurodiversity, embracing the individual strengths that people with autism bring to the table, while also recognizing and not dismissing the difficulties that people do experience. We want to make sure that we're celebrating parts of autism while also recognizing that this is challenging. It's not always beautiful like we might hope that it would be. In fact, a good proportion of the autistic population, about 25 to 30%, would be identified as having severe profound autism. And these are people who have really pronounced autistic characteristics that make life really challenging. We're also wanting to recognize that there are folks who have gifted intellectual profiles who also have autism. And that might sound like a nice combination, but in reality, that can be incredibly challenging too. So here, what we're trying to do is embrace that natural variation within functioning and focus on patient-centered outcomes rather than the diagnosis itself. We're also hoping to improve equitable and dignified collaborative healthcare. And there are some really nice efforts that I'll give a sneak peek to at the end in efforts to do this. And truly, our recommendations must be patient-centered and individualized because every single person on the spectrum is different. And their abilities and needs are going to vary and evolve over time, as should our recommendations. And this is all in efforts to promote a more inclusive and accepting environment. I think you've gotten the point already, but recommendations should never be based on a single piece of information like a diagnosis. And this, I'm going to call back to this again because I think it's such a good image that really describes there's a lot going on. So the autistic characteristics that someone experiences are a single part of what's going on. We also know that their cognitive skills, their language skills, those impact how we might perceive autism. They also impact behavior. And then we're thinking about some of the co-occurring medical, genetic, and mental health conditions that really influence the way in which we offer recommendations. So we've talked briefly today about early intervention and medication use. This is a really bare bones timeline of developmental disability services. And we are not going to focus on many of these components today, but we are going to talk about outpatient specialty services kind of at a broad level. And we're going to start with behavioral therapy, as this is one of the most common recommendations made for autistic youth. There are a lot of different forms of behavioral therapy, some that are well based in evidence and some that are not. We're going to talk about these kind of in broad strokes. At the top, we're going to talk about short-term problem-focused interventions, and then we'll delve into more intensive interventions. Short-term problem-focused interventions are exactly what they sound like. We're identifying a specific problem or areas of problems that we are trying to address within a short amount of time. And this is typically done through really utilizing a parent's behaviors as the kind of mechanism of change in terms of a child's behaviors. So this would be done typically in a clinical setting, about an hour a week, where a parent and a child are coming in and discussing the areas of concern and learning strategies for dealing with that at home. Then they go home and practice and come back and tell the clinician what did not work or what worked really well. More cases than not, what did not work. And then they discuss ways in which to make that a little bit more effective within that family's unique situation. These are going to be therapies like parent management training or parent-child interaction therapy. And I want to be clear that while there are a lot of different types of short-term problem-focused therapies, the goal here is to make sure that someone is following some sort of evidence-based framework. It doesn't mean that that needs to be very strictly curriculum-based. It does mean that there needs to be identified mechanisms of action that someone can apply and then use flexibly within a specific family's context. Now, within the intensive interventions domain, we're really thinking about interventions that are going to be, of course, much more time intensive, much more behaviorally intensive, and often more geared towards working directly with the patient or the child in efforts to increase social communication, pro-social behaviors, decrease problematic behaviors like self-injury. And of course, there's also a layer of increasing a child's ability to comply with tasks when asked, which is one of the criticisms of some of these more intensive interventions. Intensive interventions often occur multiple hours a week and can be done in the home setting, so a more naturalistic setting, can also be done, though, in a clinic setting in a more structured environment. And both of these have pros and cons in terms of their generalizability of skills learned in therapy. All of the therapies, though, all of these behavioral therapies generally have an understanding that all of our behaviors that we engage in have a purpose, meaning that there's a function behind that behavior. There's a reason why I'm engaging in it. And all behavior, regardless of what kind of behavior it is a form of communication, meaning that even if I'm throwing a big tantrum and everyone is very upset with my behaviors, I'm still communicating something in that moment. Might not be very adaptive, but I'm still communicating. The other piece that really is an important contextual principle for behavioral therapies is that we're operating under the assumption that our environment impacts our behaviors, meaning that our behaviors can be modified based on environmental outcomes too. So this can be understood through the ABC model of behavior or the antecedent behavior and consequence model. And really this identifies that there's something that precedes a behavior that we engage in. There's something that is kind of prompting that to happen. The behavior then occurs, and then something in our environment happens as a consequence of our behavior. And the consequences within this context don't mean negative consequences exclusively, but both positive and negative. What happens? This is really helpful, and I think a nice way of understanding behavior. And just a very quick example of this would be, let's say I am at a party, and there are a bunch of people around, and here I want to be funny, and so I tell a joke. Everybody laughs at that joke. That would be the consequence. So the joke is the behavior, the party is the antecedent, and the laughter would be the consequence. That laughter is giving me some positive feedback that that's something that I should do again. The opposite could be true. So let's say the same situation, I'm at a party, I tell the joke, nobody laughs. That lack of response is going to make it potentially less likely for me to engage or tell that joke again in the future, depending on how aversive that experience was for me. So this is kind of the framework under which we're thinking about some of these more intensive interventions like ABA or applied behavior analysis. And I'm going to be talking a little bit in detail about ABA just because of the controversy of ABA. I think it's important that we understand as clinicians what we're getting into, what are we recommending and why. So ABA really is an umbrella term for interventions that are based on operant conditioning paradigms. And this is, again, the idea that our behaviors are modifiable. And this is done through reinforcement and punishment paradigms. And punishment in this context specifically is simply referring to something that is occurring, either being added to an environment or taken away in efforts to make something less likely to recur, not necessarily the punishment in the colloquial way that we use it. Some of the goals that we're thinking about with ABA are related to decreasing the frequency and intensity of challenging behaviors, increasing preferred behaviors, and improving functional and social communication. So again, aligns very well with the behavioral model. But I think it's important to recognize that because of our history of attempting to make autistic people look more neurotypical or become more normal, that's the framework through which this intervention was developed. And that's one of the biggest criticisms of ABA is that we're potentially attempting to make autistic people look like neurotypical people or have less autonomy. The other criticism, though, is because of, again, our history, ABA was created within a time where we were using a lot of punitive and abusive strategies. And those were commonly used in practices of ABA. And so we are learning from people who've gone through ABA in the past that they endured a lot of abusive strategies and experienced trauma because of that. Thankfully, we've developed some more modern approaches for ABA. That being said, there are continued critiques about curriculum-based approaches, but overall, if we follow the literature and the current guidelines, we are making sure that whenever ABA is implemented, that the specific goals are actually individualized based on what that person needs. And that all of the strategies that are being used are within the current best research, really trying to identify what is going on. Oops, didn't mean to advance there. But the goal here really is to identify what the patient needs and what the family's values are, and never trying to just make a child compliant, but rather teaching them strategies that they can use and choose to use whenever they feel like they need to. Very, very high level overview of behavioral therapy. And now we're going to jump into some psychotherapy. This is in efforts to treat co-occurring mental health conditions in autistic kids. We know that autistic children face mental health conditions at a much higher rate than the general population. And in fact, the current pooled prevalence estimates for anxiety disorders in autistic kids is about 20%, which is incredibly high. Depressive disorders, about 11%. And in comparison to the general population, anxiety disorders tend to occur around, I think it's 7%, and depressive disorders maybe around 5%. Maybe it's opposite, but it's much, much higher. And the other piece to consider here is that not only are they experiencing these conditions at higher rates, they're also dying at higher rates because of suicidal ideation and more successful suicide completions. And so we need to make sure that we're screening for these conditions in our autistic patients rather than assuming they can't experience these things because they have autism. So when we do have these conditions, what do we do? What do we recommend? The psychological interventions, our counseling recommendations that are recommended are really going to vary based on what is happening for that patient. So what is their age? What are their cognitive skills? What's the functional impact of their autism, but also their mental health condition? what's available to them? Are they in an environment where the only thing available to them is telehealth and they have spotty Wi-Fi? How do we go about increasing accessibility for patients who need that? We're also thinking too about cultural considerations within these interventions. Below in the second section here, you're going to see that there are a lot of common evidence-based treatments for mental health conditions in neurotypical people. So cognitive behavioral therapy, DBT, dialectical behavioral therapy, as well as other different strategies. The message here that I want you to have is that all of those strategies are effective for autistic people too. The change is that they might need to be modified just a little bit. So the idea here is that while most of those therapies have not been validated within autistic populations, we know that modifications to evidence-based treatments overall are effective. So we might need to be adding in some prerequisite components such as teaching an emotional vocabulary before we jump into CBT, or adding some teach back methods. So making sure that instead of just cruising right on through that intervention, we are making sure that someone has actually heard what we've said. We also might want to consider some multimodal teaching strategies. Here today, I'm talking at you the whole time. I'm showing you some slides, but this is a challenging method of learning. It's hard. It's hard to keep motivated. It's hard to stay focused, but it can also be really challenging to recognize that sometimes when we are teaching someone really important, teaching something really important to someone, that might not be landing for them, even though we think it is. And so we want to be able to make sure that they're getting everything they need out of that intervention. One of the most common modifications is increased caregiver involvement, as well as a stronger emphasis on behavioral frameworks. So that cognitive piece of cognitive behavioral therapy can be pretty tricky for some kids, just given how abstract thinking about your thoughts is. And so we might be really emphasizing or leaning into that behavioral side more. When we treat mental health conditions in autistic youth, oftentimes we're leaning on both a behavioral and psychological intervention as well as medication management. And this is, again, kind of formed within that medical model of disease and disability. But then we're also thinking about what the other strategies and supports someone might need are. So when we think about autism generally, we're integrating typically some educational supports, developmental disability services, extracurricular programs. But then when we're adding in a mental health component to an autistic person, that's even more necessary, that we're leaning on some of those societal structures. So really leaning into that social model of disability as well. So what do I do? What do I recommend for my autistic patients if they're coming to me with any sort of problem? Do they want to work on behavior? Do they want to address their anxiety? This is a really, really basic roadmap that I created based on a bunch of literature. This is not anyone's specific model, but I do think that it captures a lot of different aspects that we're trying to accomplish when we're working with autistic patients, and making those recommendations individualized and patient-centered, but also collaborative. The most important thing that I want you to hear is that it needs to be collaborative. We are in, and I get in this pattern of just like telling people what to do. And what we need to be doing is taking that extra minute to collaborate and recognize what their goals are. Because I might have goals, but they might not be the same ones that the family has. So once you identify what those goals are, we want to make sure they're achievable and feasible. So we might need to help a family kind of tweak them a little bit to make sure that they are achievable. And then we want to consider what the individual and contextual characteristics are. So again, going back to, are these services even accessible? What are the cultural considerations? What is that child's kind of engagement and functioning? What are they going to benefit from? And then we want to understand with the achievable goal and with our contextual factors, who are all of the stakeholders at play? And then how do we balance those things? If we're thinking about anxiety that's occurring in the home environment, maybe our stakeholders are just the family and the child. if we're thinking about anxiety that might be occurring mostly within the school environment, how do we get the school on board and engage with them a little bit better too? When we're considering kind of what those interventions are going to be or what we're going to recommend ultimately, we really need to be considering everything that's been tried before. It might not have been an intervention related specifically to anxiety in this example, but maybe something that was related to managing behavior. What worked well? What didn't? How do we utilize that information to make sure that we're offering the best recommendation for the family and the child right now? And then finally here, we want to make sure that we are prioritizing things in a way that's really effective and setting the family up for success. So offering them the education that they need to make sure that they can go to a therapist and say, okay, here's what I know about the intervention that I'm supposed to be receiving. Are you going to be able to do that? And how am I going to know if it's not effective? Or how am I going to know that this isn't evidence-based? So really, this is the whole goal of my talk today. I didn't go into detail about really any of these interventions or offer much new information, but the goal is to make sure that you're able to then also teach families, here's what you should be expecting, here's what it should be looking like, but also your role is the most important thing. The fit between you and that person and making it clear that your values are an equal partner within that therapeutic relationship are critical. So really this comes down to empowerment. We want partnership with our families. We want honest communication. They need to know what to expect and how to advocate for themselves and their children. And our goals really should be focused on improving a person's quality of life rather than reducing the amount of effort that someone is putting forth with them. I'm going to say that again because I think it's a really good one. We want to improve a person's quality of life rather than reduce the amount of effort that we're putting forth with them. Oftentimes we equate those things together, but it's actually that's not true. We want to make sure that whatever is occurring individually in that therapeutic relationship is helping that patient rather than the people around them. Oftentimes those things coexist, but still. And overall, we want to maintain a sense of autonomy. They need to feel like they have control in what of what they're doing. What are these interventions driving? And how do we make sure that they can use these interventions in a way that feels right to them? So today we've talked about a little bit the why and the how we recommend interventions, and it continues to develop. We're still learning. We want to make sure that within this really nice kind of array of characteristics that we're supporting people well, and we're doing that in a way that evolves over time and with the patient. Okay, so here's a sneak peek, really briefly, a sneak peek of what you can expect in the future. This is related to healthcare for people with neurodevelopmental disabilities, not just mental health care, which is what I focused on mostly today, but this is a really nice consensus statement that drives home the point that autistic people, people with other neurodevelopmental conditions, deserve individualized, equitable, and quality healthcare. And this article offers some nice guidelines on how to do that. And in the future months, so in early 2025, we're going to be having one of the authors come to Phoenix Children's and talk about this. And I think it'll be a really unique opportunity for us to partner together to make sure that we're doing that well for all of our patients. One last shameless plug. Dr. Raz and I are hosting our first Autism Educational Summit this weekend, actually, Friday and Saturday. Friday is the provider day. We are completely sold out for in-person seating, but you can attend in person or virtually if you
Thank you.
learn more. Okay, I'm going to stop sharing, and I think Dr. Raz and I are open for questions.
Yes, feel free to sign up. We have some of our very own speaking. We're very excited. A great panel of speakers coming up. I wanted to open up to any questions here, but Dr. Kruer did post a question. Thank you so much. It's specifically about, are there scales that we might find helpful for quantifying autism-related symptoms and tracking them over time, such as the CARS or Gilliam, and which do you prefer and why? So I'll speak to this a little bit, and Dr. Phelps, you can jump in as well. So I would say, as far as a autism symptom specific rating scale, we're going away from that largely as far as utilizing that in progress over time. I'd say if there's any sort of scale that we would utilize to measure progress, it would be more of an adaptive rating scale, such as the Vineland or the ABAS. I'd say in practice, generally, it's not used routinely, but I'd say if there was any point when family or support services wanted us to better understand the child's needs, we would use an adaptive scale because that really tells us about that individual's functional skills and their limitations in those skills at that point in time. Because it's really more than focused on right, that, as Dr. Phelps had mentioned, right, that child's needs, the individual's progress and success, and really help focusing on their limitations. Because again, sometimes those autism symptoms, as we recognize them in our diagnosis, may not be areas that need to be changed or improved upon in certain ways. If they are limiting them, certainly in education or their desire for socialization, then certainly we'd want to support them in understanding how to engage in ways that are meaningful for them. But I would say we're utilizing more of those adaptive skills and understanding and supporting them over time and understanding their needs. Dr. Phelps, do you have anything else to add?
No, I think you said it beautifully, and I said no, but I'm going to add something. I think it's incredibly important to recognize that we're shifting a little bit in our understanding of autism, and in the way that we are not necessarily aiming to treat all autistic characteristics, and progress isn't measured necessarily based on those characteristics reducing, but it's rather the ones that are causing functional impairment. And so that's where the adaptive skills rating scales would be more effective. So a good example is we have a longstanding history of recommending eye contact goals. I really don't need eye contact to recognize that someone's paying attention. And we know from autistic people that that's really hard. And maybe, maybe having someone make eye contact is actually reducing their cognitive ability to then pay attention to me. So that would be just an easy example of something that, you know, we might have had a goal, and we might have measured over time. Actually, we did measure over time how someone made eye contact, but now we're moving away from utilizing that as a measure of progress. So I don't use any of these rating scales to track symptoms over time, but rather I would get that information from the family based on what they feel like is important, and then potentially do an adaptive skills rating scale.
Okay. Well, feel free to reach out to either of us if anyone has any questions, or join us on Friday for our inaugural Autism Summit. Thank you all for being here with us this morning. Have a great rest of your day and week.
Thanks. Bye.